информационной части этой части нашей конференции слово для руководства, для модерации предоставляется доктору Барбаре Касман-Келлер. Для дискуссии объявлено 3 вопроса. Первый вопрос — это применение имплантов искусственной радужки при аниридии. Второй вопрос — критерии для хирургического вмешательства при аниридии. И третий — консервативное лечение глаукомы у пациентов с аниридией.
I will take up the first question, which is the question for the artificial iris implant. And I'm quite interested to hear the answers of the colleagues. In my opinion, this is twofold. First of all, the lack of iris is not the biggest problem of the child or of the adult with aniridia. It is the complications which make the problems really, and which worsens the life situation during the years to come. Of course, from the aesthetic point of view, some parents would like if they wear an iris, but it is don't overestimate the iris for the visual acuity. The child who has been born with aniridia has a macular hypoplasia and often has an optic nerve dysplasia, and the missing iris is not the major problem for the low vision, and therefore I would not advise to implant an artificial iris. Because apart from these aspects, there is this other aspect of provoking an aniridia fibrosis syndrome, and to provoke the onset of glaucoma, and to provoke the onset of cataract if you do it in an eye with clear lens. Often it is done together with a lens extraction or a cataract operation. But still, it is the implantation of a foreign body with pigment on it. And the pigment is known to disperse from the artificial iris and provoke the glaucoma problems as well as the corneal problems. So I would advise against it. And I'm quite happy to hear some other comments now from the board. What about the colleague from Helmholtz Institute? Do you routinely implant artificial iris?
Я полностью согласен с доктором. Мы не имплантируем радужку по той же причине, что существует большое количество рисков у ребенка, кроме отсутствие или наличие радужки, и та же глаукома, катаракты и так далее. Любое вмешательство в такой глаз, оно увеличивает риск развития дальнейших осложнений в несколько раз. Поэтому я считаю, что не стоит.
Dr. Freeman?
I agree that there is too much risk for the benefit. And it should only even be considered if you're doing cataract surgery because of opacity. I would highly discourage it just for the sake of aesthetics. We published the first paper on aniridic fibrosis syndrome, and our theory is that any device or any surgery that may rub the periphery of the anterior segment may increase the risk of aniridic fibrosis syndrome. And the more hardware in the eye, such as an Ahmed valve, such as a lens implant, can potentially increase the risk of this, and there appears to be an association with more intraocular surgery. So my initial instinct would be to say not to do this device. However, having said this, I do know of a case in the United States where an artificial iris was used that was placed in the bag, and the patient, it really helped to her photophobia and also helped her self-esteem. So my initial instinct is to have very great caution and to discourage the use of artificial irises in Aniridia, but there are some benefits for some patients, and but I think it is not worth the risk.
Thank you. Did you hear anything new you would like to tell us on the conference in Cheboksary?
I did not see a lot of presentations on the artificial iris. They're actually happening today, unfortunately. I did see some patients, and what I heard from talking to the doctors is that in traumatic aniridia, which is totally different from congenital aniridia, they've been using these devices since 1995, and they have some long follow-up with these. And I think in traumatic aniridia, they are useful and can be very helpful. I believe they stated in congenital aniridia, they have been used since 2005, and I did see some patients, maybe they showed me the best ones, I don't know, but that were looking good maybe 8 years after the original surgery. To me, if the artificial iris is in the lens capsule and does not make significant contact with the peripheral structures, this is one thing. If it is in the sulcus and has peripheral contact, that is another thing. I would worry about aniridic fibrosis syndrome. They, in discussion with the doctors, state they have not seen a lot of that. I also know that with lens implants in the United States, many times we have to fix the lens implant with a suture to the sclera, and this provides a potential point of scarring or fibrosis to develop. But to prevent dislocation of the lens, there's not another way in our hands with our tools. Perhaps the artificial iris fixates the lens so it won't dislocate, and there may be an advantage there, but overall I'm still very cautious because of the potential for fibrosis. It is unclear what is the rate of fibrosis and how often it occurs around the world.
Would anyone else from this board here would like to say anything about artificial iris? And are there any more questions from the listeners concerning artificial iris implantation? No? Then we go on to the second question, which I think is a bit a difficult question. When patients with aniridia should have surgery and when not? Well, it depends. This is what I can say. It is, of course, the question why the surgery should be performed and why and how urgent the thing is. On one of my slides, I wrote every surgery which can be omitted is a win for the patient. This is true. But you have, of course, to decide when you can not do a surgery. For example, if you have a glaucoma and you cannot treat it with drops and you have piling drops, 1, 2, 3, 5 drops, and your cornea surface is getting less and less good, then you have not an option. You have to do the surgery for the sake of the eye. So you always have to choose between the worst and the worst, so to speak, and then try to make the best decision for the individual eye at the moment. For cataract surgery, I would say, as I said this morning, that the one good measurement is the age of the child and the question whether you can, as a physician, do retinoscopy or not. If you can do retinoscopy and you have a good view into the fundus and the back of the eye, and then the cataract is not so much disturbing for the child that one should always remove it. But if you have a dense cataract and when you do not have a good red reflex anymore from the back of the eye. And when you cannot do any retinoscopy anymore, and you have a child within the visual development phase of below 5 years, then you should do the cataract surgery, because then the child can do some more visual development. And then, of course, with all care which can be taken, with a very small incision and without additional implants beside the lens to correct the missing own lens. And so it is always the weighing for the best of the eye and of the carrier of the eye, of the person himself. Who would like to further comment on the, and I want to again to stress, because I've said this earlier, with nystagmus and strabismus surgery. These two surgeries are of course surgeries, but they are extraocular surgeries, and they do not produce these complications as intraocular surgery does. And if a patient has a gross squint, cross-eyed or divergent eyes, then it might be very good for the self-esteem of the patient to have these position anomaly corrected. And in Aniridia, there are only very few patients who have abnormal head positions to dampen the nystagmus, but in those, this can be a very good way to help the patients as well. And from the technical point of view, nystagmus dampening surgery is just like strabismus surgery. And you can do it without putting the eye into any risk. What about the question of when to do surgery and when not? What would the Helmholtz colleague like to say? Or Dr. Freeman? Yeah.
Hello? Okay. The one point that I think is very important, and maybe it's already been said today, I don't know, is glaucoma is the most important surgery in my mind, because glaucoma damage cannot be undone by current technology. So the strategy of putting off surgery as long as you can, by our understanding, is not valid for glaucoma. If the pressure is high, too high, you'll have irreversible glaucoma damage, and then when the technology is better 10 years, 20 years later, we still may not be able to recover it. So of all the surgeries, if it is recommended, glaucoma surgery, in my mind, is the most important.
You want to say? Mm-hmm.
Я тоже поддержу доктора Фримана в плане того, что наиболее важным является повышение давления, повышенное давление, глаукома при аниридии. По поводу катаракты, как сказала уважаемая Барбара, только слишком или далеко зашедшая зрелая катаракта может быть принята, так сказать, к рассмотрению, к операции. Пациенты очень тяжелые и глаза очень, я бы их назвал, хрупкие. Поэтому принимать решение о хирургии катаракты, тем более с имплантацией интраокулярной линзы, надо очень осторожно. И этих пациентов очень, на самом деле, мало оперированных. И, так сказать, надо 7 раз, как говорят по-русски, 7 раз отмерить и 1 раз прооперировать. Спасибо.
I agree, and this is why I said this morning, I think it is necessary for the Aniridia patients to get the best surgeons of the country. And I think it is not every house, speaking of a hospital of ophthalmology or a university hospital, there is possibly not in every house is every surgeon for the Aniridia patient, and perhaps the corneal surgeon sits there and the cataract surgeon sits there, and there should be one person really telling the patients where to go for which kind of surgery, just to get the best for the patient. Vadim, do you want to add something?
Ну, я хочу добавить еще, что для хирургии катаракты есть такой критерий, это когда человек не теряет способность работать вблизи, да, то есть, может быть, читать, либо работать за компьютером, и эта способность нарушается очень сильно, да, и тогда, может быть, это показанием хирургии катаракты. Во всем остальном согласен, и иногда люди сами отказываются от хирургии, потому что они боятся что-то получить еще хуже зрение, чем у них сейчас есть. Вот. Спасибо.
I've noticed that as well, being afraid of things. And I didn't want to imply that we should wait until the cataract is mature and completely dense. But of course, in children, it's often very difficult to decide because they we can't do the standard visual tests, and they can't tell us that they can't read anymore because they still don't know how to read. And therefore, I think the retinoscopy evaluation is quite a good one to see when the cataract is optically really disturbing and needs to be removed. Are there any more comments from the panel for cataract? Mm-hmm.
What do you feel about if you're doing cataract surgery, leaving them aphakic so they have the magnification from the spectacle correction?
In my opinion, some of the Aniridia patients are myopic, and then I do leave them aphakic. That makes them wearing plus lenses, which enlarge the optical image. And this is, of course, a discussion because you have the plus of the optical correction, but you have the lost border between anterior and posterior segment. What do you yourself would say to that?
I think that if many times, unless you fixate the lens implant, you'll have a late dislocation. This can be one problem, and that by taking the capsule and leaving them aphakic and doing a vitrectomy, you may serve them well because they'll have the high plus power glasses that give the magnification, and you may have reduced the risk of touch between a piece of hardware and the periphery. You have lost the anterior-posterior division in the eye, but there perhaps is benefit, and sometimes I wonder if we just do the lens implant because that's how we always do it for cataract surgery, but I think in aniridics, it may be of benefit to have the high plus power and also for considerations like aniridic fibrosis syndrome.
Are there any questions from the listeners concerning surgical points to do when what, and when rather to refrain from surgery? The third question is how to achieve normal IOP in aniridic patients and medication. I would like to know that. It's one of the most difficult problems, as you know, and as Dr. Freeman said, it is the problem that cataract can be removed and corneas can be transplanted, or it can, at the last stage, give an artificial cornea, but the damage done to the optic nerve cannot be undone. So it is really important to get a good grip to the intraocular pressure, and in children it is the usual intraocular pressure of 20, which we say is normal for adults, is already a bit high for children, in fact. So my dream intraocular pressure for children with aniridia would be 12 to 15. And with the eye medication, of course, you always have to take the preservative-free medications, and you have to see whether the medications do not have any effect on the systemic feelings of the child. Some do lower the blood pressure, make the child feel tired. So you have to evaluate that, because children are more sensitive to the systemic side effects of the eye drops than adult persons are. it's the same dosage, and you're giving it to a small child of 25 kilos, and you're giving it to a larger man of 150 kilos. So this has to be taken in mind, and of course the corneal surface has to be taken in mind due to the repetitive giving of medications, which might not be good for the corneal surface. May I just transfer the question to Dr. Friedman for his point of view concerning that question?
About control of glaucoma with the medicines. I basically use preservative-free, and then I defer everything else to my glaucoma colleagues. But it's the intraocular pressure control is critical, and how we do it in the United States is you use medicines till you no longer can achieve adequate intraocular pressure control, and then you have to go to surgery, and that's the basic approach.
I think, Elena, you really posed the questions where you quite frankly knew or know that these are the critical questions, really. And I hope you didn't expect us to suddenly have all the answers. I mean, we didn't have all the answers before, and so we're not going to have answers today, which is a pity, but it is like that.
Thank you so much for these discussions. I think we should stop for coffee break, only for 10 minutes, because we're really late.